Good morning, everyone. My name is Eva Capera, and I'm the team leader for reproductive health PlGF Oceania. Today, I have the pleasure, together with our New Zealand distributor, ESL Biosciences, to welcome you all to this webinar, which is being presented by Professor John Hyatt. I hope you enjoyed the presentation. I will now hand you over to Vanessa, who will proceed with further introductions.
Thank you, Eva. Good morning, everyone. I am Vanessa Cutmore, Sales and Application Specialist from ESL Biosciences. It's a pleasure to be here today to host this event. Just before we begin, a few small housekeeping items to bring to your attention. All attendees will be muted during the presentation. However, you do have the opportunity to submit written questions at any time during the presentation within the questions box that can be found in the GoToWebinar control panel, and they will be addressed at the conclusion of the talk. This presentation will be recorded and future access will be provided via a link shared with registrants within a follow-up email at a later date. Today's webinar is titled PlGF, an assessment of placental function in the first and third trimesters of pregnancy. This will be presented by Professor John Hyatt. John is Head of High Risk Obstetrics and a staff specialist in obstetrics and maternal and fetal medicine at the Royal Prince Alfred Hospital, Sydney. John is also a member of the discipline of obstetrics, gynecology, and neonatology at the University of Sydney. John's main academic interest lies in population screening and the development of interventions to prevent adverse obstetric outcomes. He trained with Professor Kryptos Nicolaides in the UK and wrote his research thesis based on the underlying cardiac pathophysiology associated with increased nuchal translucency. Most of the predictive models he uses are based around the 12-week scan. John has also trained with Professor Charles Rodak, one of the fathers of interventional fetal medicine, and during his time as a fellow at both King's College and the University College Hospitals, cultivated an interest in fetal therapy. John is the director of the Fetal Medicine Foundation and a board member of ISUOG. He is associate editor for fetal diagnosis and therapy, and he serves on the editorial board for prenatal diagnosis. So now, to get us started, I would like to warmly welcome Professor John Hyatt to begin the presentation. Over to you, John.
Thank you. I'll just get the presentation up on the screen. So I'm hoping you can all see that now. So good morning, everybody, and thanks for the opportunity to talk a little bit about the use of PlGF in pregnancy management. This talk probably comes in a few parts, some are obviously based in the first trimester, others in the third trimester. In the first trimester, I wanted to, yes, sorry.
We can't see your screen at the moment.
You can't see, all right, okay. That didn't work, did it?
There we go, thank you.
Is it there now? Great,
yes,
okay.
Thank you.
I'll start again, okay. So good morning, everybody, and thanks for the opportunity to talk to this topic. The talk really comes in, I think, a few parts. Some are just related to first trimester, others to third trimester. And then within the first trimester, I wanted to talk about the value of PlGF for aneuploidy, as well as screening for preeclampsia and IUGR. And in the third trimester, talk a little bit about the value in relation to identifying problems with placental function. I think that the data is more solid in terms of its development in the first trimester than the third. I think that will become apparent to you. And I think in the context of clinical interpretation at this point in time, probably the most important area is the potential value of PLGF in screening for preeclampsia at 12 weeks. So this is, if you like, the standard of care in screening for aneuploidy, and this is to do a scan at 12 weeks. Here you can see the 12-week fetus quite clearly. We use the nuchal translucency and the nasal bone as markers for Downs, and then we add to these the biochemical markers you can see in the middle of the screen: serum PAP-A, serum beta-HCG, knowing that PAP-A is reduced in Downs pregnancies and beta-HCG is increased. So the reason I've started here is I think that this approach to screening sets a standard that we can use at different gestational ages potentially. It's using a multivariate mechanism of analysis, and it's taking a combination of factors from maternal history and wedding them to investigational tools. And here we see the use of both biochemistry and biophysical tools within the same risk algorithm. And when we take the investigational tools, we're essentially manipulating the data from raw data into a format that we now recognize as MOMS, which allows us to then generate likelihood ratios for how likely or not it is that a condition exists. So that's our, if you like, standard screening tool that we're using at 12 weeks, screening for aneuploidy. Could we use PLGF as part of that approach? We know that we can use those other biochemical markers. Well, there's a growing amount of data in the literature that shows that PLGF is differentially expressed in Downs pregnancies. So that data, I think, particularly comes over the last 10 years, has been pretty consistent in the context that the MOM reduction that you see is about 20% compared to the MOM levels that you get in normal pregnancies. And on the left-hand side from this publication by Oliver Kagan et al., you can see that there is a range of measurement of PLGF in Down pregnancies, but they are, if you like, suppressed compared to the normal range that we would see, and therefore we could use this as a tool in the same way as we use HCG or PAP-A to produce a likelihood ratio for whether you're in a normal or an aneuploid population. So that likelihood ratio is derived by accounting for factors that we know impact PLGF expression, and we know that some of those are ethnicity of the patient. You can see top left of this slide. We also know there's a small variation dependent on maternal age. Then there's an impact of maternal weight, parity, whether this is an IVF pregnancy or not, and some chronic medical conditions. Diabetes is the example here. You can also see a significant impact of smoking in early pregnancy. So we know that if we manipulate the raw data to calculate MOMS by accounting for these factors, then if we compare PLGF values in a normal population to a Down population, you can see that there's a significant reduction in that cohort. And the question then is, how do we use this? So if you just look at the bottom right of this slide, you can see two potential testing processes. The top two lines look at the potential for just using biochemistry, and you can see that adding PLGF increases the sensitivity and improves the specificity of the test. Probably more likely is the standard test we use at the moment, which is free beta-HCG, PAP-A, and nuchal translucency. So that's combined first trimester screening. We know at the moment that that picks up about 89% of Down pregnancies for about a 4.8% false positive rate. And you can see that adding PLGF potentially gives us some improvement in detection and a small reduction in the false positive rate. So that would be the simplest way to include PLGF if we were screening for aneuploidy. This is some interesting data that was published by Kypros Nikolaides just a few weeks ago in a webinar. I've not seen this in the literature yet, although I'm told it's coming. but I just wanted to show it to you because it does potentially raise an issue of how can we get PLGF into clinical practice. In our practice, we have added PLGF, so we now run a essentially biochemical triple test in the first trimester. There are other jurisdictions in Australia that say that they can't afford to include PLGF for testing. I think PLGF has significant advantages for some other processes that we'll talk about in a while. And therefore, perhaps at this point in time, if you just make a comparison between HCG and PAP-A as a combination and HCG and PLGF, and perhaps look at how they first perform for traditional first trimester screening, that's that 89% detection rate there. You can see that if you change the PAP-A to PLGF, actually you have very similar sensitivity of screening. So although my advocacy would be to add PLGF to screening tools in the first trimester, I think it will be interesting to see if there's more data that's produced and more published data that shows that you potentially could substitute PLGF for PAP-A. Now, can I get to the next slide? There we go. So another means of screening is obviously to use NIPT. It's becoming much more prevalent in Australia. I'm sure it's the same in New Zealand. At this point in time, there's no Medicare rebate for this test in Australia. So certainly I would say that combined first trimester screening is still the mainstay of our screening policy. But we could, I think, potentially move to using NIPT. Some advocates would say that we should just add NIPT to screening for the whole population. If we used NIPT, we would have significantly higher detection rates for the trisomies. You can see them on the left-hand side here. But probably equally important is you can see these extremely low false positive rates from the screening process. The problem in terms of just adding this test is one of cost. So fundamentally, the current screening program we have picks up about 90% of down pregnancies. So that essentially changes the prevalence of disease in our population from about 1 in 500 to about 1 in 5,000 pregnancies. So in other words, for us to pick up that additional case, we're now talking about screening 5,000 pregnancies to detect one case. And the added cost of that becomes extremely significant. And if you look at that in terms of a typical cost economic analysis approach to look at the incremental cost of detecting that additional case, it really is prohibitive in the context of any health economic modeling. And I think that we're always going to have a hard time trying to persuade government that they should be paying for this test. The other issue, of course, that we have with NIPT is it's often not as straightforward as it's made out. There's a whole variety of reasons that NIPT tests may not work. And although the false positive rate in the literature is declared to be very, very low at about less than 0.1%, we in clinical practice find about 6 to 7% of women will have some complication in their screening process when we're using NIPT that requires some further review and interaction with us. And I just think it's useful to just bear in mind that the literature for NIPT does not really report the effectiveness of this screening tool in the way that we traditionally have done with other screening approaches. Because typically what gets reported is the outcomes or the performance of reported NIPT tests. Whereas actually what's important in a population is the whole population, not just those where you got an answer from your screening tool. And this was in the New England Journal paper that Mary Norton published. It certainly wasn't in the abstract or in the highlights, but in the writings of the paper, you could see that they didn't report 3% of cases. And in fact, there were a significant number of cases of aneuploidy amongst that group, about 1 in 38. So certainly NIPT as a population level will not be a tool that solves all of our problems. And we do therefore have to have means of, I think, addressing some of these issues in another way. If you just look at this data, for example, if you'd included the not reported tests, then the true detection rate with NIPT is 92%, not 100%. That's not very far off what you see with first trimester screening. If you turn that the other way round and say that anybody that didn't get a reported test should have an invasive test, then suddenly your false positive rate's not 0.1%, it's 3.1%, which again is not that significantly different to what we see with our current screening strategy. So one of the things that we've advocated is using NIPT in a contingent model, and we've broken our combined first trimester screening strategy, Jan, into these 3 different risk groups. At either extreme, you can see here very low risks, we reassure them, we don't offer these women an NIPT test. At the other extreme, very high risks with combined first trimester screening, we advise them that they should have an invasive test. And there's this cohort split into 2 subgroups here, but we would call these intermediate risk women, and they may choose to proceed with an NIPT test to use this as a second tier screen to then re-stratify whether they are truly high risk or low risk. And in this way, we reduce the number of NIPT tests that we potentially need in a population screening program by about 80%. And the reason that I just comment on that is that if you look at this as a detection rate at 20%, this is a paper from the States by Palamaki and colleagues, you can see, in fact, they got rid of the ultrasound component completely. They just used maternal age, and then they did a quintuple test at 12 weeks. They had about a 95% detection rate at that 20% false positive rate that you could use in this style of contingent model. So I think PlGF first has value in aneuploidy screening because there's certainly a shift in comparison to normal populations. Secondly, it potentially has value to add to combined first trimester screening by improving sensitivity and improving specificity. And then third, it can play an important part in a strategy of contingent screening, whereby you can introduce NIPT, but actually still do it in a cost-effective way. So let's move on to another topic. So this is now looking at the use of PlGF to screen for preeclampsia. So for those of you that aren't obstetricians, preeclampsia is a very significant problem for obstetricians. It affects about 2 to 5% of all pregnancies and includes about 0.4% of pregnancies that deliver before 34 weeks. Within those cohorts of deliveries, you'll see a significant number of babies that also have IAGR. And as a consequence, we know that preeclampsia can cause maternal injury. So you can see on the left the system injuries that are described as part of preeclampsia and eclampsia. And also from a fetal perspective, preterm delivery obviously has its own risks associated with it. Worldwide at this point in time, about 70,000 women die per year of preeclampsia, and about 500,000 babies die of prematurity related to being delivered early because of preeclampsia. The other thing I just wanted to point out is the ongoing risks for mothers who have preeclampsia. We know it's associated with hypertension, ischemic heart disease, and other cerebrovascular events. So again, from a public health perspective, one would think that if you could prevent preeclampsia, you would potentially reduce the prevalence of some of these long-term health outcomes for women. So what's the situation in New South Wales? This is one of my colleagues who published a paper actually looking at the reproductive choices of women who'd had preeclampsia and whether they went on to have another pregnancy. But within that paper, you can actually identify the prevalence of preeclampsia in our population. So overall, it's about 4.5%. And You can see that about 1/10 of that is preeclampsia before this 34-week gestational age point, and the rest of this is preeclampsia leading to delivery after that preterm endpoint. So is 34 weeks an important consideration? Well, some obstetricians would argue that as the majority of disease actually causes problems beyond 34 weeks, that any test that just focuses on that 34-week cutoff is not really of value in managing this disease as a whole. And to some extent that's true, but because of the cost of neonatal care, you can see here in this calculation that comes from California, that about 3/4 of all costs related to preeclampsia actually relate to the babies born before 34 weeks. And because of the underlying morbidity that those mothers and children tend to have, which is more severe than those women that contract this disease at a later stage, as a general statement, I think that this does show that if we could actually manage this cohort before 34 weeks, that would be a very significant benefit. So just changing tack for a moment. So we know, I think, quite a lot about the etiology of preeclampsia now. I think this has become clearer over the last 10 to 20 years. And we now talk about preeclampsia being a disease process that develops through different stages. And really the features that we tend to look at for a diagnosis occur after some end organ damage. So that's down the bottom of the slide. And what we now recognize is that there's maternal vascular compromise and also placental dysfunction occurring at earlier stages of the disease process. Now, from a screening perspective, what makes this attractive is that it would be very nice to be able to identify a disease process at an early stage before you have end organ damage. The example I always give of that would be screening for cervical cancer, where the changes that we're looking for are a precancerous change, and where if we take action at that point, we can prevent the development of cancer. So a lot of the rationale for screening for preeclampsia in early pregnancy is a rationale about being able to identify the processes of placental dysfunction, possibly vascular compromise, and actually then interact at that stage with some prophylactic strategy that prevents the development of disease. And you can see that from a placental dysfunction perspective, we have a number of potential markers for that in the first trimester. Uterine artery Doppler would be one. PlGF and PAP-A are also potential markers for that. So there's only any value in screening for a condition if we can potentially prevent it. So there's a bit of controversy in that area as well, and I thought it was worth addressing that. So before I continue to talk more about screening, let's talk about prevention. So prevention's, I think, well summarized by a meta-analysis published in The Lancet in 2007 by Lisa Askey and her colleagues. This included a very significant number of trials, 31 trials, and 32,000 women. If you actually looked at the range of dosage of aspirin used in these trials, it differed significantly through the trials. And if you look at the gestation where treatment was started, you can also see it differs significantly. And the 2 points that I'd like to make are that the dosage was often very, very low. Nowadays, when we prescribe low-dose aspirin, we use 150 milligrams Nocte. And then the other thing I'd like to point out is that for most cases in this meta-analysis, the gestation was beyond 16 weeks. Despite that, even in these circumstances, using aspirin did see a small, fairly modest reduction in rates of both preeclampsia and preterm birth. Now, other groups have come along and done other meta-analyses. Probably most important of these are the group of Emmanuel Bujold, who's based in Canada, and they have looked at subgroups of these papers. So they looked typically at subgroups of women where treatment was started either before or after 16 weeks. And you can see that when they do that, they can show a much more significant reduction in risk of preeclampsia and of risk of growth restriction and of risk of perinatal death. So it would appear that starting aspirin at an early stage, certainly far before 20 weeks, ideally before 16 weeks of gestation, is an important part of this preventative strategy. And that fits well, I think, with a screening test at 12 weeks gestation. So the next question is, well, who should take aspirin? Should it be everybody? Should it just be women who we perceive to be high risk, and that might be nulliparous women? Should it be women who are documented high risk? Perhaps they've had a previous experience of early preterm preeclampsia. This argument sometimes gets also impacted by the fact that aspirin is relatively cheap as a therapy. So an aspirin tablet in Australia costs 8 cents. So let's just look at those options. If we were to just give aspirin to all pregnant women, we would need to give aspirin to about 250 women to prevent 1 case of preeclampsia before 34 weeks. And there are potentially some significant risks associated with treatment. Interestingly, there is a epidemiological study from Scandinavia, it's from Denmark, published about, I think, 5 years ago, that looked at whether there was any impact of aspirin or paracetamol on risks of cerebral palsy. And it actually showed that women who took these simple analgesics during pregnancy did have increased rates of cerebral palsy. So there is the potential risk that if we were to give the whole population aspirin, that we might have some adverse effect of that. And I think more importantly, women are quite aware that there's those potential risks. And because they're aware of those risks, that means that they typically would often choose not to take the treatment. So I've just looked at the impact of that down the bottom of this slide. So if everybody took their tablets, 100% of women took their tablets, and if there's a 90% reduction in rates of early onset preeclampsia, then you would see a 90% reduction in the rate of preeclampsia altogether. If only 50% of women take their tablets, then that reduction is only 45%. So compliance is, I think, an important issue. And from my perspective, screening really has 2 values. The first value is it makes sure that you take the whole population through a process of risk assessment. And the second is that it identifies women who are high risk, and that reinforces the concept of giving them prophylactic treatment. So just to look at the other aspects of this. So this is the American College guidelines. They actually have 2 guidelines, a little bit schizophrenic. One is for what they call very high risk women. So this would be women who had previous preeclampsia or had some chronic health conditions like chronic hypertension or diabetes. And in this circumstance, you can anticipate about 2 or 3% of your population would be in a high risk group. So actually the risk reduction that you see is pretty negligible if this is the only group of women that you treat. Another policy that they have is to give all nulliparous women aspirin, but not multiparous women. And certainly in our cohort, about 1/3 of the cases of preeclampsia that we saw were in multiparous women, and 1/6 of them were in fact in multiparous women who'd had a previous normal pregnancy outcome. So again, this just will have an impact on the overall effects of your intervention. So what's the screening paradigm that we would recommend? Well, we would recommend a multivariate approach. So when we see a woman at 12 weeks, the first thing that we do when they come into our ultrasound clinic is we sit them down for a few minutes, ask them some questions, and then once they're settled, we measure their blood pressure. We convert their blood pressure into a MOM value based on the characteristics you can see on the right hand of this slide. We take a blood test from them and we measure, in fact, we're measuring both PAP-A and PlGF, although the risk algorithm we're using for preeclampsia at this point in time is predominantly using PlGF. And you can see that for both of these biomarkers, rates of early preeclampsia, or concentrations are reduced in the population that have early onset preeclampsia. And then the third thing that we do is we look at the uterine artery Dopplers. So this is an ultrasound test. We do this at the same time we do the NT scan. It takes about a minute to do this. There is some additional training that's needed so that sonographers know what they're looking for and how to do the test. What we're doing is looking to produce a trace of the uterine artery. And when we produce that trace, we have some quality assurance matrices. So for example, the peak velocity should be over 60 centimeters per second. We want 3 or 4 nice regular peaks that we can see so that we can make appropriate measurements of the waveform. And then we combine all of those factors using this algorithm, initially produced by Leona Poon back in 2009. So we're using the uterine artery Doppler, which you can see is increased in pregnancies with early preeclampsia. Often mean arterial pressure is increased in those pregnancies as well. PlGF is often decreased, as is PAP-A. And the combination of these tools gives us sensitivity at about 90% for preeclampsia before 34 weeks, for a false positive rate of about 5 to 10%. So we have validated this in an Australian population. The original population where this was done in the UK was predominantly in Caucasians and Africans. Our local population includes a large South Asian and a large East Asian cohort, and we see very similar outcomes. So this is the ROC curve that we have for screening for early preeclampsia before 34 weeks. In fact, the data I'm showing you here for validation included just PAP-A. This was our publication back in 2013. Since this time, we've actually now switched over to using PlGF and have validated that as well. Locally to us, some people in the community, GPs, complain about the access that they have to a bespoke ultrasound scan that allows them to do the uterine artery Doppler. We do point out to them that, again, like aneuploidy screening, there's potential to use this with different combinations. So, for example, if you have no access to uterine artery Doppler, you could potentially choose to use a model that used all the biochemistry, perhaps both PlGF and PAP-A. This just shows a variety of different screening tools that might be available to GPs. And in terms of risk assessment, the calculations that can be done using the Fetal Medicine Foundation algorithm, they can be freely available to people using this calculator on the web. So just back to trying to link up prediction and prevention. So this was a study that's probably a seminal paper in this area. This recruited 30,000 women, took the high-risk women and gave half of them aspirin and the other half placebo. And there was an 89% reduction in rates of early onset preeclampsia before 32 weeks, reported in those women that had aspirin. And you can see if you take all preterm deliveries, it's a 62% reduction before 37 weeks. It's important just to recognize that there's no significant difference in rates of preeclampsia at term. We've done the same in our own local population. So these were on the left, the meta-analyses I showed you before. On the right, this is our own cohort study where we compared the group where we'd validated the algorithm to women who'd had aspirin. And we again saw a 90% reduction in prevalence of disease. This is reported on 2,700 outcomes. We've actually just done some work looking at IUGR in our population. We now have over 10,000 outcomes, And we're in exactly the same situation at this point. We have less than 1 in 1,000 rate of preeclampsia being delivered before 34 weeks. So that's over an 80% reduction at this point in time. Another paper that we're just in the process of publishing, it's just been accepted by UOG, is a paper that demonstrates that screening and paying for the costs of screening is completely dominant in a cost economic model of usual care compared to using this prediction and prevention process. And you can see that we estimate, and this is in an Australian population, we've estimated that we would save about $1 million per year by actually going out of our way to properly establish a screening program by employing people, by buying ultrasound machines. And that's on the basis of the savings that we make with a reduction in neonatal cot days. And just to put that in another way, we've actually presented this as a business case to John Hunter Hospital here, which is where Felicity Park now is based. And in that business case, we basically showed that by using this policy, we would reduce the number of maternal bed days per year by about 245. But perhaps more importantly, in a system where we're always short of neonatal cots, you can see we basically save 3 cots a year, as well as a lot of money through implementation of this process. So hopefully that paper will be published within the next 6 weeks. One final word on preeclampsia. So the data that I showed you about cost economic analysis was all based on short-term outcomes. We haven't considered the fact that we know here in New South Wales, looking at 500,000 deliveries, that if you had preeclampsia before 34 weeks, that is the most significant factor increasing your risk of cardiovascular disease in later life. And from my perspective, that is actually a more important modifiable risk than, say, smoking is for young women. So a bit of a downer perhaps for first trimester screening. We also tried to look at whether we could screen for IUGR effectively at 12 weeks. When we did this work, we only had PAP-A available to us, and we could not show significant efficacy of the screening algorithm that had been produced in the UK for IUGR. We're currently reanalyzing our data now that we have PlGF available to us. And in fact, we're also going back to test SFLIT in a population, because there is a Spanish algorithm for IUGR in the first trimester that originates from Barcelona that describes much better efficacy. So hopefully we'll be able to do that in the future. So I thought I might move to the third trimester. Just as a segue, perhaps make a few comments about what's happening with antenatal care at the moment. So in Australia, antenatal care hasn't really changed since the 1920s, 1930s. It fits the typical UK-based model. And really what we see is we see more and more visits as we go through pregnancy. And that's predominantly because we recognize that preeclampsia is an unpredictable disease. So traditional teaching was you should measure blood pressure more and more frequently through gestation. And that's reflected in this data on prevalence of hypertension you can see here. Of course, the other thing that we do clinically is we palpate the abdomen, religiously now measure the symphysis fundal height, but just recognize as well that in the context of detection rates for IUGR, that process is actually pretty poor at picking up small babies. Now, I know New Zealand is a COVID-free land, but here, obviously, we still have a potential problem with COVID. It's led to significant changes in the way that we offer medical care. The social distancing associated with keep your distance means that at the moment, I can only see about 25% of the volume of antenatal patients as I could a few weeks ago. So how could we best use technologies to change some of our antenatal processes so we don't need to see women so often? Well, I think a mainstay for that for me is the prediction and prevention strategy we've already discussed. But really, as pregnancy advances, that should change to a surveillance and intervention strategy. I think the other thing just to recognize is our model of antenatal care derived in 1929 perhaps didn't properly recognize some of the other underlying problems we have, like domestic violence and mental health, that need significant improvement, I think, in our current structure. So just back to blood pressure. So one of the things that we're advocating, so that we don't have to see women on a weekly basis at the end of pregnancy, is that women should start to measure their blood pressure at home. Obviously, this makes us more reliant on their own abilities to do this properly. So one option would be to include a test like a measurement of PlGF as a means of trying to define within this group that who have more home monitoring, who is potentially at risk of developing preeclampsia or IUGR. And we are certainly considering at the moment actually using PlGF or a combination of PlGF and SFLIT as a screening tool to identify a cohort of women who we think are potentially at risk of having either IUGR or preeclampsia, who we should be seeing more frequently from an antenatal perspective. Otherwise, we've shifted to a model where we see women at 36 weeks and then potentially at 40 weeks, so missing 3 different antenatal visits. We know that the negative predictive value of a PlGF test or PlGF SFLIT ratio at 36 weeks is very high in the context of telling us whether the pregnancy is likely to be affected by either IUGR or preeclampsia. We've certainly used the PlGF SFLIT ratio as a means of changing our admission policy for women who are hypertensive towards the end of pregnancy. So women who are hypertensive now come to our day unit, and they will get a PlGF SFLIT ratio as part of their assessment and workup. And even if they are hypertensive, provided that we have control of their blood pressure and there's some process of management of that, if they have a low SFLIT to PlGF ratio, we typically would then send them home with the knowledge that it's very unlikely that this is a disease process that is likely to fulminate in the next few days, needing delivery. And I think there's now very good data internationally that shows significant cost benefit to being able to manage these women as outpatients rather than inpatients. Just to come back to growth issues, stillbirth is a problem for us, particularly with late gestations. You can see here that we don't have many stillbirths in the middle of pregnancy, and then we have an increased rate of stillbirth at the end of pregnancy. We know that a lot of these, about 10% of them, are related to growth restriction. And on top of that, if we look at potentially preventable causes of stillbirth, this is probably double this. About 20% of preventable stillbirths are probably related to growth restriction. So screening for growth restriction is really, I think, quite important at the end of pregnancy. I showed you before that our traditional assessment by palpating the abdomen will only pick up less than 50% of growth restricted infants. This here looks at estimating fetal weight and then looking at risks of stillbirth. So you can see that the risks are much higher if we estimate the fetal weight as being small on ultrasound compared to being in a normal range. But the problem with this is that estimates of fetal weight by ultrasound are also fairly inaccurate, with an accuracy of about 10 to 15% in those formulas. So a number of people are now looking at adding serum markers as means of looking at placental function at term to define whether fetuses are at risk of IUGR. These two studies, this is the Maple and the Pelican studies, were both conducted in high-risk cohorts. So these were pregnancies that had already been defined as being at risk of either preeclampsia or IUGR. But it's interesting that in the Maple study, where they revealed the data, compared to the Pelican study where they concealed the data, if you just look down the bottom, perinatal deaths were significantly reduced by 80% by revealing this information. This is just using PlGF. And birth weights were also slightly higher in the group where the information was revealed and pregnancies were delivered slightly earlier. They were delivered on average about 10 days earlier. Just if I come back to the main table, which is a bit busy, but I just wanted to show you that they used a cutoff for PlGF of 12. This was using the old Alere bedside assay that I think is no longer available to us. But with their cutoff of 12, about 20 to 25% of their population was in the higher risk group. So I think that's most of the things that I wanted to say about the value of PlGF. I think I've shown you that I think the data is more concrete for use in the first trimester. But certainly I think I would strongly advocate using PlGF in a screening strategy in the first trimester, primarily for preeclampsia, but also I think it has value for aneuploidy. And I hope I've shown you that I think there is likely to be, I think, significant obstetric interest in the next few years in being able to access PlGF or PlGF SFLIT values in the third trimester. Thank you very much.
Thank you, John, for your very interesting presentation. I will now open the questions box and invite attendees to submit any questions, which I will read out. Okay. A question from an attendee. Why not give aspirin to everyone rather than use a complex screening algorithm to identify cases of early onset preeclampsia?
Yeah, I think that this is a very contentious issue at the moment. It's interesting. I think that the concept of screening and then giving women aspirin has now very much been demonstrated to work. And, you know, there's a slight sort of bastardization, if you like, of process where we say, well, okay, if we've shown that aspirin works in that circumstance, let's just give it to everybody because it's cheap. And it will always be cheaper than the screening process. But I think the screening process has value predominantly for two reasons. The first is that if you know that you have to put a population through a screening test, then you have to have a structure to do that. And to date, if you look at our use of aspirin, which we've recognized mitigates risk of preeclampsia, you know, there are studies that have demonstrated that only 20% of women who are high risk have actually been given the intervention. And that's in part because we've not had a proper base for the screening strategy. So I think that that's the first thing that needs to be established. And then the second is a compliance issue. So there's certainly 3 studies done in the 1980s that gave aspirin to large nulliparous populations. And only 40 to 45% of those women actually took the aspirin tablets that they were given because they didn't perceive they had a significant risk. So for me, I think that that's why we should be instigating a screening program that then defines women who are high risk, that then allows us to give women an appropriate treatment at an early stage of pregnancy.
Okay, another question. Are we able to get a copy of the PowerPoint presentation? So
yeah, I'm certainly very happy to share that. I can either do that through PE, or I'm very happy to just provide that to people directly. I'm happy to enter into a dialogue about aspects of how we've established our screening service, what's easy about that, what's difficult about that as well. I think it's interesting as a hospital, we are now very committed to this screening program. I think that we've seen the value of that across all of our obstetric and neonatal departments. So I don't think that we would ever choose to go back. So it's not perhaps just the rantings of one madman.
If we add nasal bone to the algorithm, would this improve the DR and reduce FPR?
So the answer is potentially yes. I think the first thing to say is that we now recognize that there's a plethora of markers that you could use to screen for Down syndrome. And I think in different circumstances, different combinations of those might make sense. So, it could be, for example, that you're working somewhere that actually doesn't have good access to an ultrasound service. And if that's the case, then it might actually be more appropriate to use a multiple biochemical marker screening strategy than to use an ultrasound screening strategy. On the other hand, you might be working somewhere where actually ultrasound is very freely available and you have a lot of skilled operators and actually works out at a much cheaper cost than biochemistry. So there might be circumstances where you choose to use a ultrasound based approach. And I think in that approach, nowadays, you would typically want to use more than one marker. So typically you would use either nuchal translucency plus nasal bone or nuchal translucency plus ductus venosus. I think the nasal bone has potential problems as a marker. It's quite a subjective tool on ultrasound, so it's, I think, a bit more difficult than measurement of nuchal translucency. And so some people, if they were comparing ultrasound to biochemistry, would say that the value of the biochemistry is the machine's not emotive and it does the same job on every single day of the week and doesn't have the same operator dependency that perhaps ultrasound would, and perhaps with a subjective marker that's higher. The other problem with nasal bone as a marker is we typically call it as positive or negative, and the likelihood ratios therefore are very high, and that means you swing risk very markedly on the basis of just one factor, whereas a value of the multivariate process is if you're using all of those and they're all equally weighted, then I think overall it improves screening performance. It's a rather long-winded answer, but I hope I got there.
Okay, like PAPA, is there a cutoff value for PlGF MOMs in EOP?
Yeah, so I think what you're meaning is that typically some people have used a cutoff of 0.3 or 0.4 MOMs of PAPA to define a cohort that you would go on to have some higher level of surveillance in terms of screening for growth restriction. Certainly my preference would be to use a slightly more complex multivariate model in producing risks rather than just using a fixed risk cutoff. I can't tell you immediately what that cutoff would be if I used a fixed cutoff for PlGF in our population, but I can tell you the mechanism by which I would work it out. So for PAPA, for example, we decided that we would potentially offer an additional ultrasound scan late in pregnancy on the basis of looking for IUGR in women that had a low PAPA. We worked out how many scans we thought we could do with the resources available to us, and that equated to a couple of % of population. And then we went to look for the PAPA MOM that was the equivalent of that for that strategy.
Okay, we've just had a comment come through from the audience that it has been a very clear and informative presentation. So moving on to the next question.
Thank you.
According to ACOG, multiple
Yeah.
pregnancy women have high risk of preeclampsia. So if
Yeah.
all of them should use low dose aspirin without screening, without a screening test?
I think probably the answer is yes. So they make up about 1.5 to 1.7% of our population. So it's a relatively low group or small group of women. The risk factor that you would incorporate into a screening algorithm for the fact that someone has twins increases the a priori risk when you start adding the markers, to the point that it's actually very difficult when you add those additional markers to reduce their risk above and beyond a point where they would actually fall into the low risk group. So if you use a screening approach, using a multivariate screening approach, where you use the risk factors that we've already talked about, but also applied a likelihood ratio for having a multiple pregnancy, what you would find is about 80% of your multiples would still end up in a high risk group, even if you went through that multivariate strategy. And on that basis, I think it's probably better to just say, well, let's just give all of those women aspirin to make sure that we're not missing out on that potential opportunity for any of that population.
Okay, could PlGF be used to define preeclampsia rather than using the current approach based on clinical findings?
I mean, I think that is a very interesting question. If you just look at other specialties, so cardiologists, for example, the first thing is they stop listening to hearts with stethoscopes. They use ultrasound. So, you know, this concept that we have of palpating abdomens to pick up growth restricted fetuses, in my mind, is a nonsense. You know, we should be using ultrasound to measure the fetus to tell us what size it is. But then to take that to the next step, the cardiologists, if you go and have chest pain and they wonder if you have a heart attack, then they don't just make the diagnosis on the basis of your symptoms. They then check a troponin level to work out whether you've damaged your myocardium. And in the same way, I think that for preeclampsia, instead of us being completely reliant on symptoms, i.e. what your blood pressure is, I think what's more important is what's happening from a functional perspective. And so for me, yes, using PlGF or an S-FLIT PlGF ratio as a means of saying this is someone who has elevated blood pressure and they are significantly unwell and they are likely to have a bad outcome unless you do something, I think is a good idea. So certainly from my perspective, I could see us changing the definition of preeclampsia to be one that actually relies on biochemical markers.
Mm-hmm. We have 1 minute to go before the end of our session, so just wondering whether there's any more questions from attendees.
Looks like that might be it.
Yes. Lovely. Thank you. Thank you, everyone, for your time today.
That's
Thank
a pleasure.
you, John.
And thanks for joining us. Bye-bye now.